This conference will now be recorded.
Okay, there we go. Hello, welcome everyone. Thank you all for coming tonight. I know tonight we have Dr. Fraser Henderson with us, so I'm just going to briefly introduce him and then we can get started. Dr. Henderson received his bachelor's and medical degree from the University of Virginia in Charlottesville. After graduation, Dr. Henderson served for the multinational peacekeeping force in Beirut, Lebanon. He earned the Navy Commendation Medal for his service. He then returned to the U.S. to complete his residency at MUSC before going back to active duty as commander in the National Naval Medical Center in Bethesda, where he was the brigade neurosurgeon. He then completed his fellowship in craniospinal surgery at the National Hospital for Neurology and Neurosurgery in London, England, and he became the director of neurosurgery of the spine and craniocervical junction at Georgetown. He currently serves as the director of neurosurgery at Doctors Community Hospital and serves patients at Metropolitan Neurosurgery Group in Silver Spring, Maryland. He's invented numerous devices related to the brainstem and spinal cord, and he's authored, I checked the last video, over 90 peer-reviewed articles and books. And as part of a mission to continue education about craniocervical disorders and Ehlers-Danlos syndrome, different spinal abnormalities, he's given over 190 invited presentations. And in his spare time, when he's done doing all of that, he serves on our C board and our medical board, and he's arranged countless in-person and now two virtual presentations to educate healthcare providers, patients, and their families. So we're really, really grateful that Dr. Henderson could be with us today. And with that, I'm going to see if Dr. Henderson wants to say anything.
Nope, all ready to go. Yeah.
Oh, cool. Alrighty then. So let's get started. I'm going to start with some symptomatic questions. There were two questions kind of related to vertigo. Do you know what % of Chiari patients have vertigo spells as a #1 issue? And is vertigo more typical of craniocervical instability, or is it typical of Chiari?
Yeah, I think that vertigo would be more typical of craniocervical instability. I would say dizziness is extremely common with Chiari and with craniocervical instability. Vertigo is specifically a type of dizziness where the room is spinning around the patient. So it's a more specific type of dizziness, and I'd say it's a little bit more common with craniocervical instability.
Okay. Do you know if there's a percentage of Chiari patients who typically have vertigo, or is it just prohibitively small?
No, I'd say it's a common. Millerat's paper mentions that number, and it's been a while since I've read it, but I think it's in the order of about 35%.
Okay. And we can try and locate that also and share it with the group too. What are some symptoms of occult tethered cord in Ehlers-Danlos patients?
Occult tethered cord. All right. I actually like the term tethered cord syndrome as opposed to occult tethered cord. Tethered cord syndrome refers to the symptoms and signs that arise from a pulling down of the spinal cord by a thickened remnant of what's called the filum terminal. So when a baby is in the third trimester, the distal third of the spinal cord atrophies and forms a tissue called the filum terminal, which is like a little fishing line from the end of the spinal cord to the base of the spine. And normally this is very floppy, but in some people, the filum can be thickened and become inflamed and pulled downward on the spinal cord. That probably causes injury to the lower spinal cord. It's generally assumed that pulling causes injury. And so the patients have low back pain, leg pain, numbness, and weakness, sensory loss in the lumbar and sacral dermatomes, and urinary problems like urgency, frequency, hesitancy, incomplete emptying, and incontinence. So almost all patients with tethered cord have severe urinary symptoms, which have to be confirmed with a urodynamics, which is electrical and pressure testing of the bladder to confirm the presence of a neurogenic bladder. In addition, about 10% of patients have rectal incontinence, and about half of the patients have some degree of headache due to the tethering. And in my experience, some even have increased dysphagia, difficulty swallowing. And we know in children that tethered cord can result in delayed speech. And children also have developed scoliosis. Many of them may have toe walking, where they walk on their toes, or they have their legs may be turned inward, or one leg may be slightly atrophic. Very often there are little neurocutaneous markers on the back, like a hairy patch or a dimple. And radiologically, you might see a number of findings, including scoliosis. You may see the spinal cord pulled downward. Usually the spinal cord ends at the L1 level, but in tethered cord syndrome, it may be pulled all the way down to the sacrum. There might be a thickened phylum, that little band I talked about, where it may be filled with fat, and that shows up on MRI. Sometimes we see a small syrinx, a small amount of fluid in the spinal cord in the lower thoracic or lumbar spine. And we often see spina bifida occulta, which is a incomplete lamina backbone at the S1 level. So they're the radiological findings. And when people say occult tethered cord, they're just saying that the spinal cord is ending at what is generally a normal level. But it's well established in the literature, going back to the 90s, that somewhere between 18 and 28% of those studies back in the 90s patients had tethered cord syndrome, even though the spinal cord ended at a normal level.
Okay. Sticking with some symptomatic questions. One came up in the chat. Is strabismus, so being cross-eyed, related to Chiari? And can it be made worse for tethered cord or something else being present?
Yes, you can get strabismus from Chiari malformation. And could it be worse with tethered cord? I've never read that, but I'm sure there are occasions where the tethering can exert an influence all the way up. And but I would that's not something that I would generally
Yeah.
say, yeah.
There are a handful of questions. I'm going to try and do this in a flow that makes sense from symptoms, diagnosis, and all that. So there's a question here. Are there any clinical symptoms or provocation tests that a PT, it would be safe for them to administer in clinic for specifically hypermobile EDS?
Okay, in order to diagnose Ehlers-Danlos syndrome?
Yes, yes.
Okay, yes. In fact, I think that physical therapists could be really central in the diagnosis of EDS, and they're a really great part of the medical providers, and this is right down their alley. So, number one, patients with EDS have to have joint pain. So they have, knees, elbow, the big joints, not the little ones. The little joints tend to be things like rheumatoid arthritis, the hands, feet. That's rheumatoid arthritis, lupus. But in EDS, it's the big joints. So you have elbows, shoulders, hips, and knees generally, maybe ankles, and so they have joint pain. several joints for more than a few months. Secondly, they are very hypermobile. And this may not be evident. The patients tend to be quite athletic. Most of the patients I've seen were very athletic at least in their early adolescence. But you can apply the test of hypermobility, and that's very simple. And I'll just back a little bit. But one of them is bending the thumb back to the forearm. Now, I can't bend my thumb more than that far, but if I could bend it back to touch my forearm, that would be very hypermobile. And another test is bending the little finger. I can bend my little finger back that far, but if I could bend it back parallel to my forearm, then that would be 1 point there. 1 point for each thumb going back. And then we also, if I bend my elbow, I can't even get it straight. But if you have EDS, it bends backward a little bit. And it bends 15 degrees more than normal. And the same with knees. Patients, if you bend the knees backward, introduce a little reverse bend. And so a point for each of those. And then if the patient can stand with his or her feet together and place both palms on the floor, that's 1 point. Now, for an adult, you need 6 points. Or if you used to be able to put your palms on the floor, and you're over age 40, then you can have 5 points and a history of being able to put your palms on the floor. So that's that. If you have 6 points more, then you're in the race for hypermobility spectrum disorder. That could be anything from benign hypermobility, which is very common, which is probably at least 4% of the population. It's this benign hypermobility. And that's probably one end of the spectrum. But if you have that plus the joint pain, and you have skin changes like normal person, if you pinch the skin, you can pinch it up maybe maybe a centimeter. But with EDS, you can pull up the skin and it'll tent from the metacarpal, from knuckles here back to the wrist. You can tent the skin from the knuckles to the wrist. And they also have very soft skin. They may have pysogenic papules, little bumps on the ankles when the patient stands up, and unexplained striae, stretch marks. So if they have all of those and a couple of other things, then they have EDS by the 2017 criteria. If there's a family member with EDS, then you're 1/3 of the way there. There are a few other things like a high arched palate, where the palate is normally flat, but if it's shaped like a turret inside, that is one of the findings. And there are a few more, but I don't want to forget.
No, that's great. Those are really practical too, so that's very helpful.
Any physical therapist can look up the criteria and make the diagnosis.
Yep.
It's and I get annoyed when people say, "Well, it's too difficult to make the diagnosis." No, it's not that.
I'm going to shift a little bit. There are two kind of definitional questions that people we're curious about. One of them is, would you be able to define and explain what a pre-Syrinx is?
Well, that's sort of a nebulous concept in that sometimes in an MRI you can see softening or edema in the spinal cord, and that in another month or 6 months that could turn into a syrinx, a little fluid-filled cavity. But I don't think that's been firmly established. I think that's a number of us feel that that's what it is. I think that makes logical sense. There's an injury, an ongoing injury to the spinal cord, and that manifests as tissue injury, and then later the cells die, leaving a cavity which fills with fluid. Right, little COVID back, viruses.
Oh God, don't even say that.
Yeah.
Okay. You good? Hydrate.
Yeah.
There was another question about, I guess a good thing to start with is, what exactly is a pseudomeningocele, and do they always require surgery is the point. That's the question.
Okay. So I'm sorry. A meningocele is a collection of spinal fluid covered by the arachnoid, which develops outside of the spine. That's a meningocele. So usually after some sort of injury, there may be an outpouching, there may be a tear in the dura, and the arachnoid can pouch outward and expand, and that would eventually become a meningocele. Now, if you have surgery and you get a CSF leak, the CSF can leak into the space around the spine and eventually be covered by a pseudocapsule, normal tissue that just envelops that CSF. That's a pseudo-meningocele. It's not an extrusion of meninges. It's just essentially a CSF leak. Now, if you leave a CSF leak long enough, provided the tissues over it are sealed, the meningocele will reach a pressure that's equal to the pressure on the inside of the spinal canal, and it won't leak out anymore. So it'll achieve an equilibrium, and it won't keep growing. And so many of these will eventually stabilize and then maybe gradually get smaller with time. However, many of these meningoceles can be quite painful and eventually disabling to the patient. Some of them can break out and leak CSF and then cause a meningitis. And so it's my posture to, if I see a meningocele, unless there's some reason not to, I'll go in and find a leak, fix it, or take some measure to get rid of the pseudomeningocele, take care of the problem.
A question came up. There's been talk recently about, oh man, I always say the ME part very wrong, but ME-CFS, so chronic fatigue syndrome, that it might be caused by craniocervical instability. Have you seen some similar conversations about it possibly causing, tethered cord possibly causing CFS like syndromes?
Well, so ME is meningoencephalitis, and I think that's my personal feeling is that may be a misnomer, because that implies inflammation of the meninges, like a true meningitis. And in fact, usually on an MRI, you won't see an inflammation of the meninges, and it's not. we usually don't see a big inflammation. There may be a few white cells there, but it's not a true inflammatory condition. But and that said, there's always a full spectrum. So on the severe side, with some infectious, real infections, you will see meningoencephalitis. Like Lyme's disease can cause that, for instance. But I think that a lot of patients who are diagnosed with ME, CSF, CFS, chronic fatigue syndrome, actually have craniocervical instability and Chiari malformation. And it's the only way to differentiate or to know would be to do all of the dynamic imaging and a very thorough exam and history and so on. Now, could tethered cord syndrome cause chronic fatigue syndrome? And I wouldn't say it would cause it, but it can certainly exacerbate the whole problem. I mean, fatigue can be multifactorial. There are thousands of things that cause fatigue. And tethered cord can cause severe headaches and tiredness and weakness of the lower extremities and things that make you depressed, which also, when I get depressed, it makes me very fatigued. I mean, in fact, whenever I hit a medical problem and I don't know how to deal with it, it immediately makes me tired, and so does that answer your question?
Yes. So it can make everything a little bit more complicated, if anything. There are a couple of questions about this that have come up in the questions that were submitted, and a couple of people have been asking it in the chat. It boils down to what are the imaging tests and that help to accurately identify craniocervical instability. So, for instance, types of MRIs, some types of CTs, or someone specifically asked about DMX. So I don't know if you can speak to those.
Well, for craniocervical instability, the most useful test is a dynamic MRI, upright MRI.
Can you lean a little closer? You got a little quiet. Okay. Sorry. Yeah. Dynamic MRI.
The dynamic flexion extension upright MRI. And what this involves is patient sitting up and then flexing the head forward as far as he can, and then flexing it backward. And the guy Harris back in 1994 showed that the normal people, the Bayesian, the base of the skull, base of the clivus, never moves more than 10 millimeters from the odontoid, or never moves more than 12 millimeters on an X-ray. An X-ray is actually slightly enlarged view. So 12 millimeters on an X-ray means 10 millimeters on a CT scan. But anyway, we adopted with the Chiari Syringomyelia Foundation in 2013, we adopted the standard that the skull base would never move more than 12 millimeters from the odontoid, the tip of the odontoid spine. And if it did, that represented craniocervical instability. It means the ligaments are too lax to hold the head in the right position, and that and then the head is sliding, the cranium is sliding back and forward on the spine, and that's causing traction to the lower cranial nerve roots and traction on the brainstem. That causes headache. It can good. It causes headache and all the neurological symptoms of the cervical medullary syndrome. So that's the definitive way of defining craniocervical instability. Now, if you can't have an upright MRI, then you could do a supine MRI lying down and put a pillow under the head, flex the neck forward, and then put a pillow under the shoulders and allow the head to extend backward and get a supine flexion extension MRI. And that would get you in the ballpark, 80% of the time. Now, if you can't do that, then you can do the same thing with a CT scan, CAT scan. Pillow under the head for flexion, pillow under the shoulders for extension, and then do the same measurements. And the head, cranium, should be pivoting over one point over the odontoid. Should not be sliding backward and forward. So by measuring the Bayesian axis interval, which is a distance from the base of the skull to Bayesian, the line drawn behind the odontoid is the Bayesian axis interval or Harris measurement, and that measurement should not be changing more than 1 or 2 millimeters. If you have craniocervical instability, maybe varying, up to 10 millimeters. Okay. So that's that. Now, it's very difficult to make the diagnosis with X-ray, and and for the same reasons, it's difficult with DMX, digital dynamic fluoroscopy. There's so much, such a great thickness of bone that you're not seeing one point of bone, you're seeing the full width of the bone, and you lose the accuracy, and it makes it much more difficult to, for me anyway, to make the diagnosis of craniocervical instability.
Kind of stay with radiology for a second. There's a very specific question that I have a feeling came from an engineer or a radiologist, so I'm going to ask it almost verbatim. CSF flow abnormalities on axial PC MRI cine are seen in symptomatic Chiari patients, Chiari 1 patients, that are certainly the result of elevated CSF pressure, to be specific. Although it appears there has never been a direct and invasive measurement of CSF pressure in mild traumatic brain injury patients, it's likely that some degree of elevated pressure might be present. Would a similar non-invasive diagnostic for mild traumatic brain injury be plausible and perhaps supersede the be complementary with the Glasgow Coma Scale? What do you think?
So my 200-page response. Okay, well, let me pick at a few sides of that question. If you have a head injury, typically there's a little bit of bleeding, and a little bit of blood is known to increase cerebrospinal fluid pressure and can cause acute hydrocephalus or can cause normal pressure hydrocephalus, which is a mild increase in pressure that occurs in older people that has significant effects. It is known that if you have a head injury, that the cerebellar tonsils very frequently descend. So they did a study in Europe of hundreds of patients, and they found that after trauma, the number of low-lying cerebellar tonsils or Chiaris were like 5 times higher than the average, and so they made the logical conclusion that if you have a head injury, that very often that can cause a Chiari malformation. And there are probably 100 reasons or causes for a Chiari to develop. Some are genetic, and some relate to shape and size of the bone, childhood and babies. Some are if you have a brain tumor up here, that can cause a Chiari malformation. So there are many, many causes. And head injury is certainly one. And the moreover, you're more likely to pick up a low-lying cerebellar tonsil with a flexion extension MRI than with a supine MRI. Okay, so that said, the author of that question talked about the flow characteristics of CSF, and that flow is mostly changes in flow. It's mostly the result of obstruction of CSF, and so if there's a reduction in space, then that can cause an increased speed of CSF flow through there, and if obviously if it's completely obstructed, then there's no flow. And people like Raymond Damadian, who invented the MRI, has demonstrated that the flow characteristics when you're sitting upright are quite different to when you're lying down. And so I think most neurosurgeons, they look for flow or the potential for normal flow, but they don't hang their hat on, they don't base their decision to operate on that. It's just one more thing to look at, like these measurements that I've talked about in the past. They're just something to look at to add to or take away from your decision to operate or not.
Okay. I'm gonna do one more question about radiology. Do you know if any doctors, especially now given everything going electronic with COVID, are doctors willing to read those extension and flexion dynamic MRIs remotely? And if so, how do you get that kind of testing read?
Yeah, well, I think everyone who does craniocervical work, I have two, colleagues, and we all read them remotely, but we do it in conjunction with the, you have to look at it in conjunction with the full history and so on. You're going to have wildly abnormal measurements, and the patient may not need surgery at all. You have to put it all together. I know Dr. Bolognese, and I think everyone who's doing craniocervical work reads these things remotely, even in Europe. Yeah.
Okay, that's great. That kind of leads into getting into the surgical questions we have, because the first one that I can kind of see flowing well is what are the criteria for surgical intervention for, say, a teenager or an adult with Chiari, craniocervical instability, and EDS for either a decompression alone or a decompression fusion?
All right. Well, if they have a Chiari, if it's a small Chiari, usually they just need a wide but relatively small decompression, a foramen magnum decompression. If it's a big Chiari, then they usually need a bony decompression, and usually opening up the dura and putting in a patch to expand the dural space and allow normal CSF flow, and take the pressure. Has to be enough space so that the cerebellum tonsil, the cerebellar tonsil, is not pushing on the brainstem. So, and if you're doing a big enough decompression with a big dural patch, there's a significant risk of a meningocele forming, because you've got several inches of closure, and if you just leak one drop of spinal fluid every hour, in a week, you will have a meningocele. So And if you get a CSF meningocele, that can be a major impairment to effusion. So that's the Chiari decompression. Now, if they have a craniocervical fusion, and the decision to deal with the Chiari is based upon a significant headache attributable to the Chiari and the presence of some neurological findings, like lower cranial nerve findings, abnormal gait, maybe some spasticity. So there would be the criteria for doing the Chiari surgery. Now, most patients I take care of have craniocervical instability is the major problem, and with or without a Chiari. And so if they don't have a Chiari, then I don't do decompression. If they have a small Chiari, I do a small decompression and then a fusion stabilization. And if they have a big Chiari, then I'll take care of the Chiari first and then come back and do the fusion stabilization. Now, the indications for a craniocervical fusion would be a significant headache, usually 7 or above. Occasionally, I'll do someone with a headache less bad if they're clearly, if they've done, well, let's go on. Occasionally, I'll take, lesser headaches. And the presence of a cervical medullary syndrome. These are all the symptoms attributable to pathology at the craniocervical junction. So that would be, the headache, neck pain, nausea, dizziness, maybe vertigo, visual changes, diplopia, blurred vision, altered hearing, tinnitus, ringing in the ears, choking, dysarthria, difficulty speaking, dysphagia, difficulty swallowing, or odonophagia, painful swallowing, altered sleep architecture, sleep apnea, abnormal breathing, weakness, and sensory loss. So they're the symptoms, and dysautonomia. It's a dysfunction of the autonomic nervous system. These are all the everything that happens in your body that you don't have to think about. It just happens automatically. Then, on top of the symptoms, they have to have demonstrable neurological findings. So they should have numbness, almost always weakness. There's usually hyperreflexia or spasticity, instability of gait. They may be wobbly, positive Romberg, where they close their eyes and they lose their balance, and a number of other neurological findings. I want to see, clear neurological findings to back up the symptoms. And then they have to have tried, made a reasonable go at non-operative treatment. So physical therapy, neck brace, medications, isometric exercises, avoidance of those things that make their craniocervical instability worse. And so usually I see patients after they've been doing this for a year or sometimes 10 years, before they get to me. And so almost every patient has already run the gamut of non-operative treatment. And but when there's clearly no logical alternative, then surgery works well. But it's not to be embarked upon until you've done the easy, safe, easy things. Right. Does that answer your question?
Yes. You had mentioned a little bit there that there's some risk of CSF leak if that's not sealed up well. Oh God, I lost the question. How often do you find CSF leak in patients with CCI, especially if they're hypermobile?
I don't know how many CCI cases I've done, but it must be, quite a number. And I don't remember once in a while, if we're doing a craniocervical fusion stabilization and a small Chiari, there may be a tiny hole in the dura and we'll sew it up. But I don't remember there being a meningocele with a craniocervical fusion. That's pretty uncommon.
Okay.
But if you were to do a big Chiari, then it would be much more likely, yeah.
Okay. So there's a follow-up question, and I think you covered this last week or whenever that was. Oh my God. Is there a particular type of neck brace that you recommend? Does it need to be fitted to the individual? And why a 3-week neck bracing rather than traction?
Well, I think, well, first, the brace I recommend is the Vista brace. And it has a little clicker on the front and it allows you to adjust the height. And so, and the Velcro, you know, you can tighten up the vest to fit a small neck, or you can, you know, loosen the Velcro and accommodate a big neck. So I found that the one brace seems to fit about 85% of patients. If the patients have a lot of temporomandibular joint problems, then the brace, the Vista brace, by pushing upward on the jaw, on the mandible, can exacerbate the TMJ and cause severe headache. In those patients, a Miami J, which is more on the side, is more comfortable. So they're the that's the brace that I prefer. And then the other part of your question.
Why 3-week neck bracing rather than traction?
Yeah. Well, it's a little hard to walk around. You know, when I recommend bracing, I tell people put on the brace for 2 or 3 weeks and wear it night and day. Maybe take it off for meals, but otherwise wear it. But the neck muscles would atrophy if that patient did not do isometric exercises. They must do isometrics, build up their neck muscle while they're in the neck brace. The neck brace allows for the neck to gradually get realigned and settle down, and some of the inflammation and pain to go away. Most patients get much better in the neck brace. Now, patients would all feel better with traction, but it's a little bit hard to have someone walk around behind you holding your head up 24 hours a day. And you know, that's the good old days. We don't have, you know, traction. You know, we used to do a lot more traction in neurosurgery, but I think you know, with the hypermobility disorders, you know, one of the problems is the ligaments are too stretchy, so they feel good when you stretch them out, but they don't. You know, really, we want unstretching. You know, we want more stability in the ligaments, and so if patients feel better in traction, that's maybe one indicator that they might do better with fusion stabilization. But when we do the fusion stabilization, we're not really fusing them in a state of traction. We're fusing them in the ideal state of alignment without stretching things. So I'm not opposed to the concept of it, but in my view, it's a little impractical.
Kind of bouncing off that, there are some questions. What is the natural history of CCI and atlantoaxial instability without a fusion? So the question really is fusion inevitable? And what are the non-operative treatment or therapeutic options, especially for pain?
Well, Claire Francomano and Peter Rowe and my colleagues and I are actually beginning a study right now to compare non-operatives with operatives but that's still retrospective. It's really hard to do a prospective study because if someone really needs the surgery, it would be very cruel to say, I'm sorry, I know your pain is an 8 or 9 out of 10, and you feel like you're going to stop breathing every other night, and every week you feel like you're having a mild stroke, and you can't work and you can't do anything, but we're keeping you in group B. You're the experimental control group, and in a year or two we'll get to you. I mean, that'd be a little cruel. So it's really hard to do a prospective study. But most of the patients I see, they weren't diagnosed like yesterday. I mean, they may have been diagnosed a few months ago, but they've been dealing with this problem for 10 or somewhere between 1 and 10 years already. So I think that my guess is that of say 100 people with severe craniocervical instability who might need surgery, let's say who met the criteria for surgery, if you didn't operate on them, that maybe over time 10% would recover. I'm talking over a few years. Maybe 10% might recover enough to do something useful. And I would think the other 90% would all be on disability and live in misery the rest of their lives. That would be my expectation based on the 2,000 odd patients I've looked after.
Okay. What are the non-surgical treatments to kind of get you until you get to that state where you need a fusion? So like physical therapy, and there's actually a question that came up about cell regrowth, like stem cell therapies and stuff like that. I wonder if you have any thoughts.
Yeah, well, the basic things are physical therapy, not range of motion. We don't want to increase range of motion. We want physical therapy to stabilize the spine from the lumbosacral junction up. So your posture begins down to the base of your spine, and it begins with pulling in your core muscles in the abdomen, and then it proceeds up the thoracic spine and up to the cervical spine. So only a physical therapist knows how to, or maybe some physiatrists and some osteopaths know how to correct the spine from the base up. Secondly, they need to strengthen the spine, build up the muscles around the spine. Thirdly, they need to avoid all those activities which are damaging to the ligaments in the neck. Like any contact sports, anything from roller coasters to bumpy boat rides or bumpy car rides, or even getting bumped on a dance floor, or sitting in front of a computer with the neck flexed or extended, or looking at the cell phone too much, or playing games, computer games. These are all things that are very deleterious to the spine. So the patient needs to adopt a perfect posture. And then these patients have premature degeneration of all the discs in the neck. And so it's not just the craniocervical junction, it's all the levels below, but most of the mobility is at C1-2 and cranium C1. They're the hardest hit levels. So they need to then begin to keep their neck in a good position at all times, and not be bobbing their head around and twisting and turning, and looking down at their cell phone. They need to stay in perfect posture while they're awake, sitting, studying, driving, sleeping, sleeping on the side of the pillow, width of their shoulders, Then they need to pay attention to good nutrition, strengthen their bones and ligaments, maybe vitamin D, maybe calcitonin, calcium citrate, bone. A modicum of exercise every day to maintain muscle tone and posture and healthy tissues. The isometric exercises, as I've mentioned. Now, there are new things with PRP. There's a guy in Colorado who injects the ligaments through the back of the mouth, and that can thicken the ligaments and toughen them up. I'd be very afraid of an infection, but I presume he doesn't have many infections, or he would still be doing it. Even every neurosurgeon has tremendous respect for the craniocervical junction. And so sticking needles in that part of the anatomy, we think would be pretty dangerous, because the vertebral artery can have unusual, loops and whatnot. So they're the main things we do for every patient to do prior to considering surgery. Surgery is the last option when everything else fails. And in general, if a patient still be working and doing the things he has to do, then he should not have surgery. It's when they're clearly going downhill. And my goal is to get people back to the workplace, not on chronic disability, but back to work. And we accomplish that in about 2/3 of patients, or back to school or back to work, whatever.
Mm-hmm. Kind of to that point, we had a question submitted prior, and there was just a follow-up. Do you have any recommendations on how to basically do those day-to-day activities like you're saying? So without doing too much flexion or extension on your head. So while you're sleeping, is there a particular pillow that would be soft enough but hard enough, and maybe another way to prevent the the typing and all that?
Well, the My Pillow things really work. My Pillow.
Oh wow. Okay.
And it's not a paid advertisement. I have not. And it's getting in the habit. You can get in the habit. You can discipline yourself to sleep correctly at night on your side, and to turn every few hours. So that's something that's form the habit of sleeping correctly. You form the habit of standing and sitting, and you don't turn your head. You look at Grace Kelly, Princess Grace, perfect posture all the time. You look at Melania Trump, never see her slump or even turning her head. She's perfect posture all the time, even if she's standing there reviewing the troops for an hour and a half. And the Queen's not bad either. Queen Elizabeth. Right. So discipline and no foolishness. Activities. You might get injured.
Okay.
Okay. It is almost 8:30. Did you want me to take questions from the audience, or?
Well, I've been doing that throughout, so we're
have?
probably gonna, I'm trying to intersperse them. So we're probably gonna go over by the hour by a little bit. I'm trying. There are so many questions that have come in. So.
Oh, right. We sat at 7:30. That's right. I'm sorry.
Yeah. No, you're good.
Yeah.
Okay, so these are kind of CCI specific. In a patient with EDS and CCI or AAI, there was bilateral compression of both internal jugular veins, and they developed collateral veins and has developed collateral veins as well. Does that kind of patient require craniocervical fusion, or are those collaterals going to be surgically an issue?
I think I'm very careful to pay attention to the venous anatomy when I operate. We try to preserve all the veins, because the blood flow out of the brain occurs, half of it goes out through the jugular veins and half goes through all the other veins. the veins around the spine. And so if you go in and you trash all the veins into surgery, then you can actually probably, it's one way you could probably get more headache. Now, that's not being demonstrated. That's conjecture on my part. I think we used to think of all the blood flow coming out of the brain through the jugular veins, but actually blood flow comes out the jugular veins at night when you're lying supine. And during the day, more of the blood flow comes down through the spine and the other veins. And I think the reason for this might be that jugular veins can be quite large. And if they were just open, they were just wide open, then the blood flow would drain too quickly from the brain, and that could cause problems. And I suspect that there has to be a little bit of resistance to preserve a normal pressure in the brain, and not have this every time you stand up, the jugulars were wide open, then you would overdrain and you might get a headache, spinal headache-like thing. So when we stand, more proportionately more blood goes through the non-jugulars. So when we do angiograms, CT angiograms, a lot of the time we find that one jugular or even both may look compressed. When you send them for an angiogram, where you're not looking at a snapshot, but you're looking at the flow over a few minutes, actually the flow is much more normal. So the CT angiograms and the MRVs can be misleading in that respect.
Okay.
Of people who have CT angiograms, whatever reason, a third of patients show that compression, but only a third of those have believed to be symptomatic due to that compression. Okay. So you have to be wary. It's a bit of looking at the veins is a little bit of a rabbit hole, because it can be a little misleading. That said, in the brain, I've had many patients who presented with acute deterioration, and then we found blood clots in the major draining veins of the brain, the so-called draining sinuses, the transverse sinus, superior sagittal sinus, the straight sinus, so on. They're blood clots, and they can cause acute, alteration of behavior, memory, or everything, where the patient can become comatose. And if you had a significant and permanent stenosis of the jugular veins, that could also cause major problems in the brain. And it could cause increase in venous pressure in the brain, and that increased venous pressure would then cause intracranial increased pressure, otherwise known as intracranial hypertension, or pseudotumor cerebri. It seems like there's a tumor in the brain because of the increased pressure. However, if you have jugular venous compression, blood will always find another way of getting out, and over time, the patient will develop collaterals. So all the other veins in the head will increase, and blood will drain out of those over time, and the jugular veins will become less important. So there's a time thing here. So does that answer your question?
Yes. And then
it's a very complicated.
Yeah.
Yeah.
Definitely. Vascular neurosurgery is kind of crazy, but so I'll go back to fusion for a second. There have been a couple of questions that came in about tethered cord and fusion. So if someone needs, or I'm sorry, decompression and fusion or tethered cord and fusion. So this kind of came up last time as well. Is there an appropriate order in which those things happen? One of these patients had their tethered cord released and realized that the neck pain and the neck instability got worse subjectively. So is there a specific order in which this should really happen?
Yeah. Well, a general rule for neurosurgeons is you start at the top, go down. So all things being equal, you do the craniocervical instability first. And that's my preferred strategy. And because once in a while, the tethered cord symptoms will get better after you fix the neck. Now, in some patients, the craniocervical instability is moderate, but the tethered cord symptoms are really severe. And in those patients, it would seem logical to do the tethered cord first. And in some cases, they may say, hey, my headache actually got better after we untethered the cord. And even though they have some craniocervical instability, you might hold off on that operation. So you do the worst problem first. But all things being equal, you do the neck first and then the cord.
And so in the case of a decompression, that's higher, so you would do that first, or no?
Right. Yes.
Okay.
A decompression of the Chiari, you mean?
Sorry, yeah.
Yeah, right.
There's a question kind of specific about Duraplasty and what kind of tissue you use to do that Duraplasty and why you came to that kind of decision.
Okay. Well, you can get fascia from the back of the skull. Then you have to do a big ugly incision and shave an extra 4 inches of hair. And I don't think anyone would like that. Or you can get the fascia from the thigh, the fascia lata, and that works very well. People don't seem to have problems with the thigh incision, and that fascia is it's more difficult to use to sew in, but it grows into the dura really well, and that probably gets the best seal. Or you can use a bovine dura, which is actually the pericardium part, and that's much easier to handle. That's much easier to handle and easier to sew. You don't have to worry about the thigh incision. But sometimes the ethylene glycol that's used to preserve the dura can cause inflammation. I operated on a princess of a Middle Eastern country once, and of course, she's the one who had a chemical reaction to and so her strategy was, tongue in cheek. When I told her this was a chemical reaction to the ethylene glycol, or to the bovine dura. Next day I came in and she's saying, I love cows, I love cows, I love cows.
Just reminding yourself.
But anyway, so and then there's a so-called suturable dura, but so I think the best is the fascia lata from the thigh, but the bovine works very well too, and that's probably a little bit more standard,
Specific to Chiari 1. So say that's all that the patient would have. They have occasional headache, and they're not sure if the symptoms are necessarily Chiari symptoms. Is surgery done in a case like that, or only when it's impairing quality of life? Or would someone have a decompressive surgery, especially on a child or an adult? I guess either. sort of prophylactically, just in case the symptoms get worse, or do you just watch and observe?
Yeah, we don't generally do much neurosurgery prophylactically. You know, we don't do it in anticipation of possible problems. Number one. Number two, there are so many causes of headaches. You know, like if you have EDS, you can have a headache from mast cell activation syndrome, from temporomandibular joint problems, from instability at C2-3 or C1-2 or C2-3 or C3-4 or even C4-5, from tethered cord syndrome. You can have headaches from TIAs, a hole in the heart, you know, from abnormal vasculature, from
This goes on.
Yeah, okay. There's a legion of things. So if you're going to operate for Chiari, it ought to be typical symptoms and a headache that's significant. You know, like at least a 6 out of 10. You know, preferably 7 or more out of 10, and that it's interfering with what they need to do. You know, if they can just take an ibuprofen and that's it, then probably not worth having the surgery. But if they can't continue the work that they have to do, if it's really interfering with the progress of their life, and if they have both the symptoms and some neurological findings, congruent findings, then that's we always want the pain and disability, symptoms, findings, congruent radiological findings. They all go together, then that's why we operate.
Okay. This is more of a spinal question. Is it common for scoliosis to start developing later in the teenage years, even if it was never present before?
Yeah, I mean, that tethered cord can cause the scoliosis to develop in teenage years or even later. And could you excuse me for 1 second?
No problem. Just wait a minute. Much better. And just so everyone knows, there are a ton of questions, and I'm trying to get to all of them. I really do promise. I will say some of these questions Dr. Henderson does go over in his most recent presentation, the Q&A. So I recommend that you, if you're bored after this, you can go on to our YouTube. It's there, and you can take a look at that presentation as well. Let me see if there's anything I can ask. Ooh, the YouTube channel name, that I can do. So you go to youtube.com/ it's CSF info 2007. So I'll put it in the chat. And that's our YouTube channel. Oops, I spelled it wrong. It doesn't help. And we have all of our videos going back to, I think, 2009 on there. So there's literally, I want to say, days of videos to watch if you're bored, and still some of us are quarantined. So if you're looking for something to do, you can definitely go in there and take a look. Yeah. Oh, thank you, Mary. All right. Hello, Dr. Henderson. Okay. All right. I guess, oh, this is a good question. Do you think that a tethered cord release following a decompression and Duraplasty would have a positive effect on a very large Syrinx that can continue to persist after that decompression?
No.
Yes. No. Okay.
I think it can affect Syrinx and the lower thoracic spine, but the persistence of the Syrinx in the cervical spine, to me, and to others like Kubota, suggests ongoing instability or basilar at the craniocervical junction, or basilar invagination, or a very severe kyphosis of the brainstem.
Okay. This is an interesting question as well. Can numbing in the legs be caused by a Tarlov cyst? The patient isn't able to find a position that's comfortable to them. Do you have any recommendations?
Tarlov cyst usually causes pain in, it's a little bit more dermatomal, although it's quite possible that over time, the autonomic nerves can become involved and the pain may be non-dermatomal. But usually a Tarlov cyst, if it's on the S2 nerve, then it'll be pain in the back of the thigh. It won't be pain on the front of the leg. Secondly, a Tarlov cyst is almost always best lying down and worst sitting up. When you're sitting up, there's a greater column of pressure, water pressure from the spinal column pushing down, increasing the pressure in the Tarlov cyst, causing more pain. So that's very specific. And Tarlov cysts usually cause urinary symptoms, or often cause urinary symptoms, although I'm not sure exactly why. And but they do not cause weakness. Because they may cause numbness in the lower sacral dermatomes, especially S2, 3, 4, but they do not cause weakness.
Okay. There's an interesting question. This is an older patient, about 66. They had a really rough time earlier on with Chiari, Scoliosis, Syringomyelia. She really had like a comment and was curious to hear your thoughts on it. Recently, I said she, like I know it's a woman, I have no idea. I went vegan a few years ago and the pain issues seemed to have disappeared. And then recently they had undergone more facet locking, joint locking situations and had some steroid injections, but she or he was wondering if they should be seeing a physiatrist, or what do you think in that kind of situation? If the diet had changed some pain symptomatology.
Okay, I'm a little confused here. So they've got a Syringomyelia.
Chiari, Scoliosis, Syringomyelia. They'd undergone shunting and a lot of different surgeries. And the patient wound up doing some walking and doing some exercise, went vegan, changed the diet. Is there anything else, I guess, that you would recommend to fix some more joint locking situations that are going on?
Yeah, well, see here, a lot of the things you mentioned occur with Ehlers-Danlos syndrome. They're comorbid conditions that are happening at the same time. Like if you have mast cell activation syndrome, that can be affecting all of your joints, bladder function, and brain fog, and pain level, and everything. And so altering the diet and activities may be improving those comorbid conditions. And they're the real joker in the pack. You have to identify all of the problems and not simply assume that the problem is due to the Chiari or the Syrinx or even craniocervical instability. You have to look for all the other issues. And so it's always, the non-surgical treatments are really important. Our diet and the air. Sometimes people have allergic reactions to the air, the water, the mold in the house. These can have huge impact on the patient. And so that's one good thing about osteopathic doctors. They're a little more thoughtful about all the other components, whereas medical doctors are thinking about, what drug can I give this patient to get them out of my office, or what test can I order so they'll leave and get the test and leave me alone at least for a month. Whereas osteopaths, thinking about these things. So, all right, does that answer the question?
Yes, I think so. I'm going to try and take two more. So one of them is, are there any suggestions that you might have surgically or non-surgically in treating a teenager that has some dystonia localized in the neck with head and shoulder tremor? The patient also has Chiari and is hypermobile and unstable in some cases.
Yeah, these tremors that's kind of a very non-specific term. And I saw someone today remotely. She had, if she just touched her leg, they would just start tremoring, and that was, I think, spasticity, increased tone. And that poor girl walked in to see doctors in Florida and said, "Hey, I think I've got craniocervical instability and Ehlers-Danlos syndrome." They told her to go see a psychiatrist. Spent 5 years. Yeah, and that's exactly what she had, and she had all the neurological findings and everything to go with it. So getting a little tangential there. The dystonia is another very non-specific term, and there are 100 causes of dystonia. But instability at the craniocervical, instability in the neck, or something that's irritating the nerves of the neck or the brainstem can, I think, cause dystonia. So the dystonia could be coming from up in the brain, could be a seizure, or it could be some irritation of the nerve, the upper cervical level. And so I'd be inclined to treat that with see if a neck brace helps, and Valium or lorazepam, Ativan or Clonopin, and usually Benadryl and other anti-cholinergic drugs. There's a whole host of them, like Artane, treat dystonias. So they can be quite difficult to deal with. And then you have to, then there's something called torticollis, which is where the neck is literally, the muscles become contracted and the neck is completely bent over, and then these can be very difficult to deal with.
Yeah.
So they're tough problems.
Yeah. We're getting so close to being very late, so I'm gonna just ask one more question. I know we had extras, but I promise next time. So I think it's a good one to end on, though, because it's really about thinking about how we look at this systemically. How do we best approach
I don't want any political questions.
It's only a tiny political.
No systemic political.
How do we best approach our local health providers who are not up to date on certain Chiari, CCI, or EDS situations? And really, why is this information not making it to certain neurologists? Because they're really the first, and GPs really, they're the first line of defense for these problems. So how do we get out there more?
I won't say ignorance, arrogance, stupidity. But I mean, we didn't learn a lot about it in medical school. Probably the best thing is you don't want to offend your medical provider, but if you can come in and say, hey, I did a little research, and I have to say this fits my symptoms exactly. And I brought you an article on this. And if they're a good doctor, they'll say, "Oh, okay, well, read that," and they'll be interested in learning about it. But if you approach them well and they're not willing to learn something about it, and they just back at you, then you need to find another doctor. And so I think doctors have the sense that they learned everything in medical school. There's nothing much more to learn, and so it's kind of
Yeah, I think it's the cognitive dissonance that you just see this, how much we
yeah.
really don't know about the body, especially the brain and the central nervous system. And
Right.
I think it's just you don't want to deal.
Yeah, I mean, and the reality is most doctors, really their knowledge is 2 questions deep. So say, well, why is this? They'll give you an answer. Why is that? They might give you an answer. And why is that? And you've already hit the depth of their knowledge.
Yeah.
And but you know, for something like Ehlers-Danlos syndrome, I didn't diagnose my first patient till 2010, and it was someone in one of the nurses in my office. And I know in retrospect, I've been dealing with these patients at Georgetown, and I was intrigued by them, but I didn't know, I couldn't put it all together. But in this case, I had a nurse who was a champion swimmer, and she came to me with a back problem. And while I was examining her, for the back, I noticed a bruise on her thigh, and I said, "Well, what's that from?" She said, "Oh, I bruise easily." And then I noticed a scar on her leg. She said, "Oh, well, I had a knee problem." I thought, why would a champion swimmer have a knee problem? There must be a joint thing here. And then I thought, joint bruising, and I thought, this sounds like one of those connective tissue disorders, and I thought Ehlers something or other, and I looked it up, and then I went to meet Claire Francomano, and who was an expert on this, and she said, "Hey, can I send you patients?" And I said, "Sure." Okay, so that's the first time I'd made a diagnosis, and it's just remembering a 5-minute portion of the lecture, 25 years before.
Yeah.
And so most doctors, what they see is more circumscribed. What I see, and they're less willing to sort of expand their portfolio of knowledge.
Well, that story is super inspiring, I think, to everybody on the phone, because all it took was one patient, and look where you've come. What is this? What year is it? 2020, 10 years later. So all it takes is one patient to come in and say, "I need help." And
yeah.
All right.
Yeah.
Well, that was great.
Caitlin, thank you for organizing all of this, and Dorothy, you all have done so much for the knowledge factor. And you all are the hinges, this whole thing. And I think we would still be dark ages if it weren't for you all. And you too, Kathy.
Well, you too, Fraser.
Okay.
Thank you.
Alrighty.
Take
care. Thank you. All right. Bye-bye. Bye, Wendy.